Hi, I'm Dr. Tanya Russell from the Australian Institute of Tropical Health and Medicine at James Cook University. In the Solomon Islands, malaria is a major cause of disease. Over the past decade, the Ministry of Health has had astounding success at reducing transmission in the country, with long-lasting insecticidal nets, insecticide residual spraying, as well as improved diagnostics and treatment. However, during the last couple of years, the downward decline in malaria has halted, and there has been a worrying increase in cases. At the same time, dengue transmission has been emerging in the country. The first major outbreak of dengue occurred in 2013, and another occurred during 2016. Understanding the prevalence of malaria, dengue, and zika across the country is absolutely essential baseline information required by the Ministry of Health for effective planning and to prioritise precious resources to implement the best possible vector control program. Therefore, to assist our partners in the Solomon Islands, we surveyed the prevalence of malaria, dengue and Zika during May 2018. At the same time, we tested a novel diagnostic that could enhance rapid detection of malaria. The study was funded by two partners, being the Department of Foreign Affairs and Trade, as well as the Intellectual Ventures Laboratory. Many people, partners, and collaborating institutions were all involved in the success of the trial. The survey was conducted across 4 provinces in the Solomon Islands. We worked closely with our collaborators at the Ministry of Health, in particular the Provincial Health Directors and the National Vector-Borne Disease Control Program. And we put together an excellent team of staff that included both national level staff and local level staff from each of the provinces. It would be amiss of me to move forward without mentioning all of the work that went into planning for this trial, writing the standard operating protocols, applying for ethical approvals, and of course organising the equipment, which involved procuring, packing and shipping large amounts of equipment, which in itself was not a minor undertaking. The first provinces surveyed were Honiara and Guadalcanal, Honiara being the urban capital of the Solomon Islands, and these areas were selected because high numbers of both malaria and dengue cases are reported from Honiara and the surrounding areas of Guadalcanal. Noting that as you move away from the city, the region becomes more rural as you enter into Guadalcanal province. All of the study sites were selected in consultation with our partners at the Ministry of Health and the National Vector-Borne Disease Control Program. Each of the sites had its own characteristics particular to the area due to geography, environment and cultures. I highlight some of these differences, with modes of transport being related to conducting the field trial, and also housing construction, which is relevant for malaria transmission. In Honiara, we spent a lot of time travelling in trucks, moving slowly through very bad traffic, as well as dealing with various car issues. Here the communities are more continuous, being the capital city, and the residents live in what could be classed as improved housing, with many houses constructed from timber or fibro with either thatch or iron roofing. While in Honiara, we were joined by Professor Tom Burcock from the Australian Institute of Tropical Health and Medicine, James Cook University, as well as Stephen Burcock from the Intellectual Ventures Laboratory in Seattle, who was providing training on the novel malaria diagnostic. We held training days for the field staff and slowly commenced sample collection, while continuing with on-site training and troubleshooting. Moving over to Isabel Province now. Isabel was selected to represent a rural area of the country with low malaria transmission. In fact, the province has been slated for malaria elimination, and transmission has remained low throughout the province over recent years. We sampled villages close to the capital of Bouala, and the region was quite remote and had limited infrastructure, and all of the villages were actually quite isolated. Isabel, we once again used trucks to visit some of the villages. Yeah, getting diesel for the truck. However, some of the villages were only accessible by boat, which made for some adventurous trips in the weather. While to access other villages, we had to walk in. And boy, did we walk on some days. But we always made it there. In Isabel, the housing was of a traditional style, made locally from thatched walls and roofs. On to Malaita province now. Malaita was selected to represent a rural area in the country with high malaria transmission. Also, a reasonable number of dengue cases have been detected in this area. We sampled in villages close to Alki, which you can see on the map here, and we also note the location of the hospital, which was quite isolated from the main town and all of the other villages. It's certainly going to be interesting to compare the prevalence of malaria and dengue in this area with that of Honiara, as there is a lot of long-range movement of people between these areas. In Malaita, we were once again using trucks to visit the villages, and these are the National Vector-Borne Disease Control Program staff that were helping us out along the way. The housing was again of a traditional style, made locally with thatched walls and roofs. The villages were compact, isolated, and well kept. Hi, just checking you are still awake. If you're still watching, I can only assume that you were waiting to hear about the science and how the survey was conducted on each day when we were in the village. The initial part of the process was to request permission to work in each of the villages. This community consultation process was conducted in partnership with the National Vector-Borne Disease Control Program, who have very close relationships with the village elders. And this involved having discussions at community meetings, and the residents were asked to volunteer. Our partnership with the National Vector-Borne Disease Program was invaluable, and generally we had really great participation in the surveys. The village residents were so excited to be able to contribute to a study that was aimed at reducing malaria and dengue transmission, not only in their village but across the country. The village residents were amazing in hosting us in their villages and lining up for hours to participate. We even had a special panpipe concert. After we arrived, we met with the communities, the volunteers lined up, and the first step in the process was to complete written informed consent. The paperwork was given to the volunteer to carry with them to the next step in the process. Each of the patients was coded with a unique identifier, and for this, identical stickers were placed onto the informed consent form as well as onto the blood collection tools. The blood collection tools were organised at the start of the process, and for each patient there was one novel rapid diagnostic test, a filter paper and a blood collection tube. Next, we recorded the tympanic temperature for each of the patients and completed the patient questionnaire using the electronic data capture. It's working really well. So we have one form for the patient questionnaire, which has a number of questions on it with the study site, the village name. It's all in Pidgin. Actually, I can change it to English here. That's what we need. So after completing the patient questionnaire, the volunteers move over to the nurse to have their blood sample taken. Any of the patients that were found to be positive for malaria with the CareStart rapid diagnostic test were called back and notified. It took 20 minutes for the rapid diagnostic test to run. The positive patients were provided with malaria treatment by the nurses and given a referral letter for follow-up at the local clinic. The patient was thanked for their participation and the blood sample was passed to the field technician who performed the initial blood processing. This was to create some dried blood spots that could be used for PCR analysis, as well as to run the experimental and CareStart rapid diagnostic tests. This initial processing had to be done quite quickly before the blood started to clot. The blood tubes were then placed into the cool box and they were kept there until they were transferred to the laboratory. After the correct time period has elapsed, the results of the RDTs are recorded. For the CareStarts, this was done visually, and for the experimental RDTs, we used the Axon machine. Once again, the results were recorded using the electronic data capture system. Blood samples were then transported back to the laboratory where the serum was separated from the red blood cells. Back in the laboratory, the samples were initially spun using the centrifuges. Next, the serum was separated from the red blood cells, and both the serum and the blood cells were stored in microcentrifuge tubes. Each of the tubes was uniquely identified with a barcode sticker. The samples were then stored in cryo boxes. The provincial hospitals were wonderful partners, and they really helped us to keep the samples cool in the field. They made fridges available to us, which was really excellent, especially considering the conditions that they're working under. Here's Isabel Hospital. This is the main pharmacy, and they really need some shelves and additional supplies, so it was really wonderful that they could help us out. The samples were packed up in cool boxes and we transported them back to Honiara. We were able to store the samples in freezers at the national medical stores, which was really wonderful. We then shipped the samples to the molecular laboratories for further processing with a special dry ice shipment. The samples were sent to James Cook University in Cairns, to Intellectual Ventures Laboratory in Seattle, and to the London School of Hygiene and Tropical Medicine.